Hello everyone, welcome back. Today I'll be covering regarding a supracondylar fracture humerus in children, my final year master exam questions. I hope this video will help you too. Now let's get started. A 5-year-old boy complained of pain and deformity of the left elbow. Radiograph shows supracondylar fracture of left humerus. Question A. What is the classification and relevance to treatment? 7 marks. Gartland classification is the most commonly used classification. Gartland type 1 is undisplaced fracture. Gartland type 2 is displaced fracture in one plane. Gartland type 3 is displaced fracture in 2 or 3 planes. I commonly use the Wilkins modified Gartland classification system. This picture illustrates the Gartland classification. The above picture is a Gartland classification for type 1 is undisplaced, type 2 is displaced in one plane, type 3 is displaced fracture in 2 or 3 planes. Below is the modified Gartland classification. Type 1 is non-displaced. Type 2 is divided into 2A and 2B. 2A is intact posterior cortex, hinge in extension, no rotation or translation. Type 2B, intact posterior cortex, hinge in extension with some degree of rotational displacement or translation. Type 3 is complete displacement. What is the relevance to treatment? Depending on fracture classification, treatment options range from non-operative such as close reduction and/or tape, splint or cast immobilization. Operative management include close reduction and percutaneous pinning or open reduction and pinning. There is no controversies for type 1 is always conservative management and type 3 is always operative management. Controversies arises regarding type 2 fractures either conservatively versus operatively. Question B. Radial pulse is not palpable but the fingers are pink. What is the treatment? 10 marks. The treatment for pink pulseless hand is controversial. Some surgeons advocate for aggressive exploration and vascular reconstruction, while others recommend close observation after urgent close reduction, percutaneous pinning, CRPP, and some do advocate observe for 24 to 48 hours. If there is no return of pulse or compartment present, then go in for the open reduction and exploration. KIV, fasciotomy. I would choose an urgent CRPP. It is supported by the previous study that collateral circulation is sufficient to support the vascularity of the limb following supracondylar fracture, even without fracture reduction. Close observation of the vascular status after CRPP is indicated. If there is signs of deterioration of vascular status, immediate surgical exploration is indicated. Making decision of whether to perform surgical exploration requires accurate evaluation of the vascular compromise. The evaluation include arteriography and color flow doppler ultrasound CFDU. Computed tomography, angiography, CTA, and MRI magnetic resonance imaging is not really done pre-operatively due to it will only confirm the known diagnosis and it will delay the exploration. The disadvantages of arteriography include its invasive nature and the risk of hemorrhage at the puncture site and allergic reaction to contrast agent. CFDU, color flow doppler ultrasound, is non-invasive and easily attainable. Preoperative CFDU will help to show whether there is a presence of disruption of the brachial artery flow that will indicate the need for vascular exploration. Postoperative CFDU is useful for determining the severity of arterial compromise occurred during the CRPP procedure and to confirm the continuity of the artery. Nerve injury is also taken into consideration for immediate exploration of pulseless limb. Now we are talking about journal. According to Luria et al., a significant correlation was found between the medial nerve deficit and vascular injury. Ramachandran suggested that coexisting ischemia is an indication for vascular exploration. Mangat et al. Recommend early exploration of Gartland 3 supracondylar fracture in patients with coexisting anterior interosseous or medial nerve palsy, since this appears as a strong predictive indicator of nerve and vessel entrapment. C. Discuss the advantages and disadvantages of lateral pinning versus medial and lateral pinning. 8 marks. The advantages of lateral pinning is avoidance of the iatrogenic ulnar nerve injury. The disadvantages of lateral pinning, the main one is the construct is less stable biomechanically. There is a failure to provide torsional stability. There is an average loss of carrying angle, Bowman's angle, and the range of movement due to the less stable construct. There is risk of loss of reduction after lateral pinning. So how can we avoid it? It can be minimized by following proper pin technique with divergent pins and use of a third lateral pin if needed. The advantages of the medial lateral pinning mostly is increase in mechanical stability. The disadvantage of medial lateral pinning main is the iatrogenic ulnar nerve injury that may result from placement of the medial pin. This risk can be reduced by inserting lateral pin first, avoiding hyperflexion of the elbow during the medial pin placement, and by retracting the nerve more posteriorly by digital method before medial pin placement. The risk also can be reduced with a mini medial incision as reported by Kocher et al. And with extension of the elbow during the medial pin placement. Yay, we have reached to the end of this video. I hope you have learned something. See you in the next one. Take care and bye.